Hi folks, it's Amit Pawa here. Now this is one half of a short pro-con debate I took part in when I attended a meeting of regional anaesthesia in Lausanne, and I was debating Professor Eric Albrecht, and the title of the talk was Liposomal Bupivacaine should be routinely used in the daily practice. So that was the title of the talk. Obviously this is a little bit tongue-in-cheek, and Professor Albrecht was very gracious in me having a little bit of fun at taking on this challenge. So hopefully you're going to enjoy what we have to show here. So that was the title of the talk that I was given, but I changed the title up. So I think the title should be Liposomal Bupivacaine has a role for some patients in daily practice. My disclosures are, as you know, but the big one, of course, is Pacira Pharmaceuticals. And Pacira Pharmaceuticals is the company that manufactures liposomal bupivacaine, or Exparel. So you'll all be thinking, does he have a conflict of interest? Well, I have consulted for Pacira in the past, but I no longer hold this post. And so I still wish to use this drug. So surely that says something about the drug. What I'm going to show you for the next 15 minutes is that we need long-acting regional anaesthesia. Single-shot regional anaesthesia is the way to do this because I don't believe that catheters are the answer. And contrary to what the papers say and what some people say, I believe that liposomal bupivacaine works. This is the bit where it gets a little bit fun. Would you eat a meal from a chef that had never tasted his food? I just want to put that out there. Would you take drug advice from a doctor who has never administered that particular drug? Now, leaving that in your mind, Professor Eric Albrecht is a prolific researcher. He's a highly paid academic who's published lots, but has no experience of using liposomal bupivacaine. On the other hand, there's me. I'm a regular anaesthetist. I'm a clinical practitioner. I haven't published much, but I do have plenty of experience with using liposomal bupivacaine. So I'm just going to leave that out there as we go into a bit more detail. So what is liposomal bupivacaine? Well, liposomes are naturally occurring, biodegradable and biocompatible lipids that come as a formulation. And liposomal bupivacaine is a multi-vesicular liposomal drug delivery system which contains bupivacaine. And the whole idea is that bupivacaine is released over time. And the membrane components of the liposomal bupivacaine are cleared by normal metabolic pathways. And if you look at this electron microscope view, it kind of looks like a pomegranate, I guess, which contains particles or molecules of bupivacaine that get released over time. Now, liposomes are not new. They've been used since 1995 for many drugs and have a long-standing history. So what is liposomal bupivacaine licensed for? Well, there are different indications actually between the USA and UK and Europe. In the USA, it's licensed for interscaling brachial plexus block, for popliteal sciatic and adductor canal, which are relatively new indications, and for field block or infiltration. In the UK and Europe, it's licensed for brachial plexus blocks in general, for femoral nerve block, and for field block and infiltration. And the whole idea of providing this formulation is that it should prolong the duration of single-shot regional anaesthesia. So why do I think that we have a need for liposomal bupivacaine? Well, single-shot regional anaesthetic blocks tend to last less than 24 hours, no matter what drugs you use. And if you look at the surgical pain trajectory, it's clearly longer than this. And this paper looks at knee arthroplasty, hip arthroplasty, mastectomy, and shoulder scopes. And as you can see, the numerical rating score for pain can continue to a number of days outside this 24-hour period. So after that period, when the nerve blocks wear off, we then rely on opioids. And for many reasons, we know that opioids are not ideal. So currently, what are our options for extending a block? Or we can use additives, that would be perineural additives or intravenous additives. We can use continuous infusions such as catheters, or we can use liposomal bupivacaine. Now, when we look at additives, there are a whole host of additives that we can use. Adrenaline, buprenorphine, alpha-2 agonists like clonidine and dexmedetomidine and dexamethasone. But many of these additives, when used perinaturally, are off-label use. And if you use something off-label, you need to consent the patient for that. But they still only give you 24 hours duration. And probably of all of those additives, the one that's talked about the most is dexamethasone. There are some issues with dexamethasone, however. If you look, it can cause vasoconstriction, it contains neurolytic preservatives, in vitro neurotoxicity, can increase the blood glucose, it can crystallize when used with bupivacaine, and when we've looked at studies on ulnar nerves in volunteers, it doesn't affect the block at all. It can also increase the motor block, but the duration is still less than 24 hours, and as I said before, it's unlicensed and off-label use. So the question is, do you still want to use dexamethasone, the widest used additive of all, with all of these potential issues? Now, interestingly, all of the information I got from 2 papers, of which Professor Albrecht was one of the authors, which I think is fascinating. So what are the issues with catheters? Clearly, they take a skill set to insert them. It's not the same as doing a single shot block. The disposables associated with catheters cost more money than just doing a single shot block. There is a cost, both financial and in time when it comes to siting these, a cost of the pump, as I said, and also the infrastructure you need to set up around the catheter service so you can troubleshoot everything. And also what happens when you put the catheters in and they come out. That's a problem because suddenly the patient who's pain-free is now suddenly not pain-free. If you send these patients home or onto the ward with continuous infusions of local anaesthetic, there is a risk of local anaesthetic systemic toxicity. So you could do all of that, or you could do a single shot block. Now, a lot of people have got concerns with the risk of liposomal bupivacaine and toxicity, and we happen to know that the maximum tolerated plasma bupivacaine level is about 2,000 nanograms per mil. Now, in this interesting graph from this paper over here, the study looked at knee arthroplasty patients, and they compared 2 groups. Those that had a continuous femoral nerve block plus local infiltration analgesia, versus those that had local infiltration analgesia with Exparel or liposomal bupivacaine admixed or mixed with bupivacaine. And if you look, the continuous femoral nerve block group, who had their local infiltration analgesia as well, had plasma levels of bupivacaine that in theory exceeded the plasma levels of bupivacaine that should be tolerated before getting toxicity. So those that had a continuous femoral nerve block, their plasma levels of bupivacaine went really high, as opposed to those that had local infiltration analgesia with Exparel and bupivacaine. So look at that height, that peak of plasma level. So I would say, do you still want to use a catheter over liposomal bupivacaine? There's another paper here, and this paper again with Eric Albrecht as an author looked at single bolus injections of local anaesthetic with or without continuous infusions for interscaling and brachial plexus blocks. And what they found, well, there was no difference in analgesia between catheters and single shot blocks after major shoulder surgery when patients were given multimodal analgesia. So do we still need to use a catheter over liposomal bupivacaine when it doesn't look like catheters offer us any advantages? Okay, so check out this paper. This paper was looking at the quality of recovery after rotator cuff repairs when patients had interscaling liposomal bupivacaine block versus interscaling nerve catheters. And what did they find? Well, they found that interscaling liposomal bupivacaine significantly improved the quality of recovery compared with catheters. So again, this is not great when we're looking at the use of catheters versus liposomal bupivacaine. It looks like liposomal bupivacaine was better. So why is liposomal bupivacaine attractive? Well, there are no special skills required to site the block. You just site the block as you would do a single shot block. It's a one-off cost. Yes, it's more expensive than using bupivacaine alone, but that one-off cost means that you don't then have to worry about disposables, the infrastructure afterwards, the time taken to insert this specialist catheter. No extra monitoring is required other than what you would do for a single shot regional anesthesia. You get a prolonged sensory block, but without an extended motor block. No special equipment is required. It's safe to use, it's tried and tested, and there isn't any real risk of local anesthetic systemic toxicity, and you could still use the drug with multimodal analgesia. So are there any tips with how you can use liposomal bupivacaine? Well, yes, there are. This medication is a suspension, not a solution like normal local anesthetics. It doesn't behave the way that usual local anesthetics behave. the suspension stays exactly where you put it, and you have to be close to the target nerves. You can't rely on depositing the local anesthetic suspension away from the target structure and hope it will diffuse across that. But when you want to use it for surgical anesthesia or for analgesia, it's beneficial if you admix it or mix it with standard bupivacaine, because a free portion of bupivacaine within this suspension isn't necessarily enough to give you sufficient surgical anesthesia, and sometimes in analgesia it's made better when you admix it with bupivacaine. Now, I'm going to talk about some other papers, but I'm not going to talk about liposomal bupivacaine versus placebo because I don't think that adds any value. The first paper I'm going to talk about comes from 2017, and in this paper they looked at interscaling brachial plexus blocks with 0.25% bupivacaine versus an admixture of 0.25% bupivacaine and liposomal bupivacaine together. When you look at this table, what it shows you is that liposomal bupivacaine, which is the blue line, reduced the pain for up to 7 days post-operatively, and certainly was associated with enhanced patient satisfaction. Here's another paper here, and in this paper they took 80 patients for total knee arthroplasty, and they performed an adductor canal block with liposomal bupivacaine and bupivacaine versus bupivacaine alone. When they looked at this data, liposomal bupivacaine significantly reduced opioid use for up to 72 hours, again longer than the duration you would expect from a single shot block with bupivacaine alone. There's another paper here, and this was a retrospective observational study. They looked at 42 patients with surgical liposomal bupivacaine versus no liposomal bupivacaine, the historical data, and the group that had liposomal bupivacaine for these posterior lumbar fusions had a lower total opioid consumption. This is surgical use of liposomal bupivacaine. In March 2024, there was a paper looking at the use of liposomal bupivacaine for ultrasound-guided rectus sheath blocks after midline laparotomy. They looked at 3 ASA3 patients who were having a midline laparotomy, and they all got rectus sheath blocks with bupivacaine and liposomal bupivacaine admixed, and they got good analgesia post-op for immediate post-op and up to 2 weeks later. That's pretty impressive. They also noticed there were minimal opioid requirements and patients were discharged on day 2 or day 3. So I know what all of you are going to be saying, because I'll be saying the same. What about negative papers? Are there any papers that have shown bad things? Well, listen, I've got you. This is a paper that was done in healthy volunteers. Remember the ulnar nerve? We talked about ulnar nerve with dexamethasone. Well, here they did ulnar nerve blocks in healthy volunteers with bupivacaine alone versus liposomal bupivacaine alone. And their primary endpoint was sensory block success and duration. Now, interestingly, only 32% of liposomal bupivacaine volunteers got a sensory block. Now, I'm not entirely surprised by that because there's only a small fraction of free bupivacaine in the liposomal bupivacaine. But what did the authors conclude? They concluded the results show that liposomal bupivacaine is not suitable as a sole drug for intraoperative regional anesthesia. Finding of its limited long-term efficacy adds to the existing evidence that a moderate effect at best should be expected on post-operative pain therapy. Now, this has nothing to do with the endpoints of the study. No one was talking about using it for intraoperative regional anesthesia. This was done on healthy volunteers for an unproven indication. So I would take that result with a pinch of salt. Now, this paper is the paper that gave the company some bad press. Now, what did this paper show? Well, this paper showed there was a statistically significant but not clinically significant improvement in postoperative pain when they looked at a whole host of liposomal bupivacaine papers in this systematic review and meta-analysis. But when they excluded industry-sponsored trials, they concluded that this difference was not significant. But if you look at the details of this paper, the meta-analysis including studies with unproved indications, with non-established dosing, and non-peer-reviewed data. But actually, there was a clinically significant visual analog score reduction of 1, and this paper over here by Paul Miles talked about how the fact that if you have a change of 10 for the 100 millimeter pain scores, it is significant. There was another paper here. Now, this paper was authored by Eric Albrecht, and this was a systematic review and meta-analysis. and they concluded that liposomal bupivacaine statistically reduces pain scores at 24, 48, and 72 hours without clinical relevance. And if they looked at their pain scores, the reduction in pain scores at 24 hours, it was 0.9 out of 10, 48 hours, 0.7 out of 10, and 72 hours, 0.7 out of 10. So they said there was a statistically significant reduction, but it wasn't that relevant. But actually, if you look at their data in a bit more detail, they included field blocks and peripheral nerve blocks and lumped them together. There was an obvious benefit of 1.36 at 24 hours with peripheral nerve blocks, but field blocks have little benefit. So there's clinical heterogeneity when you can look at those two different groups, and combining them makes the overall result look worse. But actually, when you estimate the rest pain scores for the controls, they're about 3 out of 10. So if the controls have got a rest pain score of 3 out of 10, actually a reduction of 0.9 or 1.36 is actually much more impressive when the baseline pain score isn't that good. So do I have any experience of liposomal bupivacaine? Yes, I've used it for elbows and for shoulders as part of brachial plexus blocks. I've used it as part of my full knee recipe for total knee replacements, and I've even used it as ESP blocks for spine surgery and rectus sheath for laparotomy. I haven't published my results, but I have observed significant reduction in opioid requirements and pain scores, and I'll show you some examples. So his first example was a patient who had an ankle fusion, and I performed a popliteal sciatic nerve block with liposomal bupivacaine, and this patient didn't require any analgesia and had no pain at all post-operatively. I followed them up daily. They got an 18-hour motor block, but a 7-day sensory block and no pain. This patient had revision thoracic spine fusion, and I performed erectospinal plane blocks with liposomal bupivacaine. They used minimal PCA morphine use, and they were discharged home on day 2 after this procedure. I think that's pretty impressive, and I don't think I could have achieved that without this medication. This was a patient who had a total elbow replacement, and I performed an infraclavicular brachial plexus block with bupivacaine and liposomal bupivacaine. The only medication they took post-operatively was paracetamol, and this video was taken 24 hours post-block. So I think what I've shown you is that we need long-acting regional anaesthesia to minimize opioid requirement and prolong the benefit patients get from their nerve blocks. Single-shot regional anaesthesia I really think is the future. You can achieve those outcomes by using liposomal bupivacaine. Catheters are not necessarily the answer. They're not straightforward, they cost money, they require infrastructure, and in the examples I've shown you, I think I've shown you that liposomal bupivacaine works. So, I've not published my experience, I'm just a regular anaesthetist. I want the best for my patients. I want to reduce pain and opioid requirements, and I do have some experience with liposomal bupivacaine. And I urge the audience who are listening at the time to think whether they would trust a doctor who's never used the medication at all. So I think that liposomal bupivacaine has a role for some patients in daily practice. I hope you've enjoyed this talk. Of course, it was a little bit tongue-in-cheek. I just want to state from the outset that whilst I did have a conflict of interest with Pacira, I no longer hold that conflict of interest. But this was there just to kind of get you to think a little bit and hopefully make you open your eyes a bit to the opportunities that are out there. Many thanks.